one of the newer techniques called the serratus anterior plane block, or also sometimes referred to as the SAP block. So a couple goals and objectives. So we'll go over some of the background of the SAP block, the anatomy and the innervation of the block, and then what equipment we use, which is probably going to be nothing new. The technique with some ultrasound pictures in the video, and then just quickly touch on the comparison and like a little refresher of the PECS 1 and 2 blocks in comparison to the serratus block, and then go over a quick summary. So in terms of the background, like I mentioned, the serratus plane block is a somewhat new ultrasound guided regional anesthesia technique of the thorax. You can see it on the right side there. And I think they started doing them only around like 2011 or so. And very similar to the PECS 1 and 2, it involves interfascial injection of local anesthetic. And the target is to block the upper intercostal nerves that innervate the chest. So it was developed as an alternative, or used as an alternative to a thoracic epidural in people who can't have epidurals, let's say, an alternative to paravertebral blocks, intercostal blocks, and intrapleural blocks as well. And initially, like we touched on this morning, it was initially indicated for analgesia for rib fractures, and I did one in residency and a few in fellowship for people who couldn't have, a thoracic epidural based on the fact that we're anticoagulation. It works pretty well. And just like also the PECS blocks, just like the TAP block, it's considered a quote-unquote volume block or a compartment block because you're making a space within a potential space, and you're injecting large volume, dilute local anesthetic, targeting multiple of the peripheral nerves that we mentioned. And the effect is what contributes to most of the pain is going to be the nerve irritation from the surgery, from the cuts and incisions, and as well as the muscle spasms that occur post-operatively. And this is kind of the majority of the origin of the pain that comes from these surgeries. A little bit on the anatomy. So you can see that on the right side there's a picture of basically the axilla and some of the muscles of the chest and abdomen. So the serratus muscle, serratus anterior muscle is in the lateral chest wall. It's deep to the latissimus dorsi muscle posteriorly, which we'll see is a very, very helpful landmark. And then you have the pectoralis muscles anteriorly, specifically the pectoralis minor. This is just another representation of the previous slide in coronal section. So it's at the level of the glenohumeral joint, and in the red circle there you can see the medial, the serratus anterior kind of right on top of the rib and the thoracic wall, and you can also kind of see that small little muscle belly is the pectoralis minor anteriorly, and then you have the latissimus and the teres major posteriorly. Couple notes on the vascular supply to the muscle. It receives a serratus branch of the thoracodorsal artery, which comes from the axillary artery. And mainly practically speaking, the only reason why I would mention this is it's a very helpful landmark in people who don't have good delineation of the latissimus or the serratus, etc. So if you turn on your color Doppler, you can see the either the thoracodorsal artery itself or the serratus branch, and you can kind of navigate from there. In terms of the nerve innervation, or the innervation again, so we're targeting the lateral, intercostal, and a little bit of the anterior intercostal branches of those cutaneous nerves. And again, on the left side, you have a little bit of a different kind of cross section. You can see that the nerves start obviously in the spinal cord and they wrap around, and then there's perforating branches that become the lateral and the anterior branches. There's posterior branches too, but we're not really targeting those. So, and then as I have written there, if you you do it correctly, the analgesia is for the nerves of T3 to T9, and they perforate through and kind of fan on top of the serratus muscle. In terms of the equipment, again, shouldn't be anything new, but basically that's the, on the right you see the picture of the positioning of the probe. You want to obviously prep the skin sterilely, you want to have sterile gloves, and you have a 30 cc syringe with local anesthetic, usually 30 cc's or 25 cc's of 0.25% bupivacaine. You can also use, I've used 0.5% ropivacaine, you can use metbuvacaine as well, 1.5%. You want to use not too long of a needle. You want to use a 22 gauge regional block needle, like the PIAMs that we have, that are 50 to 100 millimeters of length. And then you're using the 6 to 3 megahertz linear transducer. Again, this block is not very deep. You don't need it curvilinear usually. And the depth is between 1 and 4 centimeters only on regularly sized patients. And like I mentioned, you can also use the color Doppler to assist in identifying the vessels. And you can see on the right too, so some of the other landmarks. The coracoid process can be potentially a good landmark as well, because it's right by the axilla, in order to count the ribs, which we'll talk about. So there's a couple of different ways to position the patient for this block. I've mostly done it with the patient laying supine with the arm abducted. It makes things, obviously you're putting your transducer by the axilla, so it makes things easier for that, but also it exposes some of the anatomy a little bit better. People can also do it in the lateral decubitus position, especially if somebody is already on the table in the lateral position for something like a VATS. You can do it that way too, and one is not usually better than the other, but that's just kind of how I think most people do it. And you can also have the arm forward if the abducted arm is not making it any easier. You can try to have the arm kind of go forward. Again, the transducer is going to be in the mid-axillary line at the level of the 5th rib, and there's a couple ways to navigate the plane of where you want to be. So you want to place the transducer more in the coronal plane, and you basically first you count the ribs from the clavicle. So right below the clavicle is usually going to be rib 2. You can count down from there, more kind of in the mid-clavicular line, and as you kind of go down, you can move the transducer laterally and a little bit posteriorly to get to the latissimus, but at least that'll give you the rib landmarks. Again, you want to be by the 4th and 5th rib for this. You can also place the transducer just at the axilla, and you can pretty easily usually identify the latissimus, and that'll also be one of the landmarks as well. The other thing I pretty much always did for these blocks is that you always want to tilt the probe a little bit more posteriorly, so this way a little bit, and to expose the latissimus. So this picture is the picture on the left is kind of the positioning in the lateral decubitus position. It's a little bit different from what the actual ultrasound image shows, because I just want to note that the transducer should be more in line with the body instead of in the sagittal plane. So usually, like I said, the probe is this way as opposed to that way, but they're doing it like this here. And then you can see the layers at that level, and on the top is obviously the skin, to the right is the cephalad or anterior, and on the left is going to be posterior caudad. And here is just a little bit of a more clear view. So the latissimus is going to be on the top. Again, that's your landmark. At that level, the serratus is going to be below that, and the intercostal muscles are below that, with the pleura and the rib separating the intercostals.
Can you flip back to the...
Sure. So, rib, intercostal, serratus, lat. And your target is going to be, as we'll talk, either here or by the rib. So, I'll show that in a minute.
crank up the depth, obviously it's easy to see the abdominal cavity. Is it kind of the same thing here? Like, does that help you see, like, once you see the chest, then just work your way backwards from the chest cavity?
Yeah, I think.
In terms of finding layers?
Yeah, I think, like I said, if you don't focus on placing the probe immediately at the spot where you sort of have to be, but instead work from upper and go down, it's much easier to identify things instead of just placing the transducer right there and then like trying to guess what's what, because it's much easier if you see.
You said typically start mid-clavicular line?
Yeah, I mean, let's say you have an obese patient and you would start in the mid-clavicular line, you'd get the ribs, you'd start counting the ribs, and as you go down, you kind of move this way.
Okay.
But you end up over here by the axilla.
Okay.
So you move it the same way you would do for a PECS block. You know how you start here and you kind
Sort of, yeah, but you end up in a different spot. So we'll
Right.
see later that the PECS block is
It's
going to
more
be more
anterior.
over the chest, and this is more lateral posterior. And then this is just another picture of the same anatomy, just with the needle there. So you're just to be clear. So this part is going to be the already injected local anesthetic. This is not a muscle belly. The serratus is going to be over here. The lat is kind of displaced, I think, over here. And then you're going to inject right in that spot.
Is this a position you like to use?
I've done both. I think, so the way we did it in fellowship for mastectomies, or I'm sorry, for VATS, it was preoperatively. So we just have the patient supine with the arm abducted. But if you do it when they're already on the table, which happened a few times, this is also a good way. I don't think it really makes one better than the other. You're still identifying the same stuff, almost in the same position, but some people prefer one over the other. I don't think it really matters.
So having the probe more sagittal versus coronal, they're showing
Exactly.
the picture here more sagittal.
Right.
Is that the picture that goes with the sagittal?
So that's what I said. So no, that picture usually goes. It's sort of parasagittal, not parasagittal, but it's in between the sagittal and the coronal. So it's kind of like on the diagonal a little bit.
It is still on the diagonal.
Yeah, a little bit,
But you're going from posterior to anterior needle insertion.
Correct. Yes. Correct. You're going caudal over here to cranial. So a little bit of a different picture and a couple of the approaches. Again, I've done this a couple different ways. So what this picture shows is, again, you have the lat, the serratus over here, the intercostals, and the ribs. You want to go between the fourth and fifth rib, usually closer to the fifth rib. And there's two approaches to the actual injection and the needle trajectory. So if this is the PEC major, PEC minor, serratus, this is going to be a little bit closer to the chest now, where you may not maybe see the latissimus. But the point of this slide is that when you're injecting, you can either inject on top of the PEC minor, okay? You can inject on top of the PEC minor, and that, the reason I have that in bold is that's kind of the more, for case reports, there's some evidence that that approach works a little bit better. What a lot of people do is they'll basically visualize this anatomy, they'll hit the fifth rib on an oblique angle, and then pull back like maybe a couple millimeters, and then inject right at the rib. Like they're not going to be worried about, making sure you're just in between the planes and stuff. And that's another approach. Like I said, I did both of these. I didn't notice a difference in the analgesia, but there's some case reports saying that if you're a little bit more precise with your needle placement in between the PEC minor and the serratus, it may be a little bit better. So just two slightly different ways to do it. So this is just a video kind of putting everything together, kind of point out things. So sub-Q tissue, serratus, obviously, this is the rib over here.
Obviously.
You're injecting, what's that?
Obviously.
Yes.
I can see the rib.
And in this, I think in this one, they're injecting right at the rib, so they're kind of taking that second approach.
Just look like the PEC minor block.
Yeah, but it's,
Position is lower and more caught at.
and you're right, because they share the anatomy.
Constantine, is that lower part, is this the PECS 1? Is this the part that's the 1 or the 2?
No, this is still this would be, this is still the serratus block,
Oh, okay.
okay? You just don't see the lat very well here. But what I'm trying to show is just where you're injecting in comparison to the planes, okay? So, and then we'll go over it again. But so the PECS now, in comparison to the PECS 1 and 2 blocks, they're very close together. The anatomy is very close together. They're pretty similar, but there are a few differences. So the PECS blocks were designed to provide analgesia to the upper anterior chest wall. The PECS 1 targets the pectoral nerves from the brachial plexus, so C5 through T1. And typically people inject, 10 to 15 cc's of local anesthetic between the 3rd and 4th ribs, whereas the serratus was by the 4th and 5th, kind of a little bit downstream. And then the types of surgeries that these are pretty good for are breast expander placement, some kind of subpectoral prostheses, or pacemaker insertion, or porticad. As far as the PECS 2 block, so PECS 2 includes the PECS 1, and that one targets a little bit more the intercostal nerves and again, the anterior and lateral divisions. And it sounds like very similar to the serratus block, but the levels are a little bit lower in the serratus block, so it's a more complete coverage of the chest. It's a little bit more useful in the more extensive breast surgery or surgery of the axilla, such as mastectomy, especially radical mastectomies. And you're also getting analgesia of the long thoracic nerve, which innervates the serratus, and the thoracodorsal nerve, which innervates the latissimus. And with the PECS 2 block, and here I'm talking about that second injection that's below the PECS 1, you're injecting about 20 cc's, so 30 total per side.
So that's one, the PECS 2 is how we usually start. We go deep right on top of the rib.
Yeah, yeah.
And then we pull back between PEC 1.
Yeah, so it's
PEC
very
1
similar
finger.
to the serratus, yes.
So you actually do the PECS 2 before you do the PECS 1.
Yeah, just to minimize the amount of, cutting through tissue. A little bit, just to rehash or review the technique. So, also similar to the serratus block for the PECS 1 and 2, you're placing the patient supine, the arm is abducted. Your probe here, so in the serratus it was placed more in the axilla. Here it's placed in the mid-clavicular line, and you're trying to first see the axillary vessels, so you might move a little bit laterally, like how you would do like an infraclavicular brachial plexus block, and then you kind of count down the ribs. So what I just said, again, level of the 3rd and 4th for the PECS, level of the 4th and 5th for the serratus, and then you want to identify the muscle planes. You want to rotate the probe slightly medially, so if you're counting like this, you want to move the probe a little bit this way. Really, the only I don't think it makes the block any better. The only thing it does is just a lot of times I found that even in like very obese individuals, it'll make your navigation a little bit better by exposing the pectoral branch of the thoracochromial artery, which runs there in between the planes, and that's going to be your target plane. And for the PECS 1, the needle insertion is going to be medial to lateral, so you're coming like this in an oblique manner, and you're going between the pec major and the minor muscles. The PECS 2, the deeper block is going to be, like you said, the needle kind of continues to the plane between the pec minor and the serratus. I think this is another video of doing the PECS blocks now. And again, it's going to look very similar to the serratus block. Is he okay? kind of hard to see, but head is this way, caudal is to the left.
That's Serratus block, have you ever put catheters in there?
What's that?
Have you ever put a catheter in for a
No, I have never done that. But
You know of it being done?
yeah, I ran across a small, like an article with a few cases being done like that, and they said it was the same, you know, as far as opioid consumption and everything, and pain and analgesia based on BAS scores as to the paravertebral blocks. So again, just a comparison slide. On the left, you see that's going to be your PECS 1. That's your target. The PECS 2, I usually do it in the same spot pretty much, because again, you want to minimize the amount of needle insertions, but technically, I guess the spot for the PECS 2 is just a little bit lower, because if you think about it, the needle is going deeper, so you are, you know, going more caudal as opposed to the PECS 1, just a little bit. And then on the right is going to be the needle or the probe placement and the anatomy on ultrasound for the serratus. So in quick summary, the serratus blame block is a newer ultrasound guided block for lateral thoracic wall surgery. So things like VATS, and also you can do them for thoracotomies. The key landmarks again are the PEC major, PEC minor, the latissimus, serratus anterior, the thoracodorsal artery, or the serratus branch, and then you're targeting the 4th and 5th ribs in the mid-axillary line, and you want to, and also you want to make sure you see the pleura as well. You're getting analgesia of the T3 to T9 nerves. Again, it's a little bit lower than the PECS 1 and 2. Again, PECS 1 is going to be more the brachial plexus innervation, C8 to T1, or C6 to T1, and then this one's going to be a little bit lower. You're injecting about 30 cc's per side of 0.25% bupivacaine, which I think is what we're going to be using. You're using the linear ultrasound probe, and you're using our standard 22 or 21 gauge hyperechoic block needle. Again, the transducer is placed more in the coronal plane. It's tilted posteriorly as needed, because you want to see usually the latissimus dorsi. And again, as per the video, sometimes you don't see the latissimus, and that's okay, as long as you're in between all the other landmarks. You just want to mainly use the latissimus to navigate and make sure you're in the right ballpark. As far as documentation for this, so they can be billed as intercostal blocks, and just like the other blocks that we perform, and the indication is going to be for post-operative pain and for surgeon's request in the EMR. And I just put that in there because, again, it's a new block. They're still kind of establishing the analgesic benefit and safety, but it's pretty promising for VATS and thoracic surgery.
So you're getting cutaneous nerves. What about like for rib fractures? Is the serratus help or not really?
Yeah, so originally the serratus was developed for rib fractures. And again, because I think with the rib fractures, you're getting a lot of that muscle spasm from the injury and the nerve irritation, which is causing most of the pain, which is why they can't breathe very well. So it takes care of that. It doesn't do anything, to the deeper nerves or anything like that. I mean, you're just targeting the peripheral cutaneous stuff.
There's a lady in ICU now with 7 rib fractures. They're doing a fixation on today. You should try that.
Yeah, because Sheree got consult on that lady, and she was asking me to do an epidural, but I guess she was concerned about infection or whatever, that lady. And that's what I was thinking about. Okay, good.
She's going to the OR today, so.
She is?
Yeah, schedule.
Are you in the OR today?
Yeah, I'm with ALCUS, so.
And are they mostly done to sleep? I mean, you said you did them in pre-op, but.
Yeah,
usually
they can be, the reason we did them awake, I think, is just more for like safety from like local anesthetic toxicity, but you can do them asleep. Just like we do the PECS.
That's the background, fake laugh.
Thanks, Connor.
We don't have the clap.
You want to see any of the videos again?